second over. Okay, so no questions. So by the way, we'll have posters for all the winners project as well as runner-up project in the vendor area. So, okay, so our next speaker is Dr. Jesse Taylor. He's Mary Downs Endowed Chair of Pediatric Craniofacial Treatment and Research.
Thank you. It's a mouthful. The best thing that ever happened to me was coming to Penn, and I came because of some really important people in my field being here. What I've learned since coming here is that the actual most important reason to come to Penn is because there are so many incredible people outside of my own field who have had tremendous influence on my career. So about 5 years ago, I started thinking about all the shortcomings of craniofacial distraction osteogenesis, which is the number one thing that has changed my field over the last 30 years, but it has a lot of shortcomings. It's painful, high rates of infection, lots of problems. So I started thinking about how could we try to make this process better for families, for patients, for children. And at about that time, Ari West came along, who's a really brilliant medical student here at Penn. And out of some discussions that he and I had, we formed a small company called Osteo that he's going to tell you about. And through some work that Osteo has done, we hope to transform the field of craniofacial distraction osteogenesis.
Thanks, Jesse. Really is an honor to be here today, so thank you. I'll tell you a little bit more about our team at the end, but first, we do have a disclosure, as Dr. Taylor said. We formed a company called Osteo through the PCI Ventures Upstart program in order to commercialize the work we're presenting here today. So the mission underlying this work and the work we're doing at Osteo is to build smart, fully implantable craniofacial distractors. And over the next few slides, we'll really kind of unpack what that means. But before talking about what distraction or what a distractor is, it makes sense to first talk about the diseases for which distraction is a treatment. These diseases are a group of mostly congenital disorders that cause growth restriction in one or more areas of the craniomaxillofacial or CMF skeleton. That's the bony skeleton of the face and or cranium. The different regions of the CMF skeleton can be seen here and include the lower and upper jaws in blue and green and the anterior and posterior vault or cranium in purple and red. In the jaw, multiple disorders can cause hypoplasticity or undergrowth of the bony framework, which can in turn cause constriction of a newborn's airway. This can lead to requirement of intubation or tracheostomy. And in the vault, premature fusion of the growth plates surrounding the brain can cause increased intracranial pressure and subsequent cognitive deficits down the line. This condition is called craniosynostosis and affects 1 in 2,500 newborns. So why are we talking about these seemingly unrelated conditions? Well, I alluded to it earlier, but the answer is the shared device that's central to repairing all these deformities. That device is a distractor. Here we can see a distractor like those on the market today. We see 2 foot plates, as they're called, with screw holes to allow for fixation of bone. We also see a shaft that connects the 2 foot plates, and on the far right side of this shaft we see what we call the activator head. And when the activator head is turned with a special screwdriver, the 2 bony foot plates and therefore the attached pieces of bone are driven apart from one another. Now when this process occurs at a controlled rate of approximately 1 millimeter a day over a number of weeks, the body's tricked into regenerating bone in a continually widening gap. So if we're looking to expand a child's posterior cranial vault, seen here in red, a surgeon can cut the bone circumferentially around the constricted region, apply 2 cranial distractors such that they straddle that new bony cut, and then these devices allow for one to gradually separate the newly cut pieces of bone in the patient's skull each day over a number of weeks, as I said. So you may be wondering, how does one actually engage and turn the distractor after the end of the procedure if it's screwed directly into the patient's bone and their incision is closed before leaving the operating room? And the answer to this question is one that continues to plague both surgeons and patients alike, like you heard in Jesse's introduction. So to allow for daily expansion of the distractor, the activator head, that's the end of the distractor shaft that I talked about earlier, protrudes through the patient's skin following the initial operation. This way, a nurse and eventually the patient's parents can be taught to turn the activator head with a special screwdriver in accordance with the surgeon's protocol of, for example, 1 millimeter a day. So at this point, two things should strike you as potential red flags. The first, the medical device is designed to be only semi-buried and pokes through the patient's skin for a prolonged period of time. Second, parents are responsible for driving the actual expansion of their child's facial skeleton after the device is placed. And if these features of current distractors sound problematic, it's because they are. This is data from CHOP showing a 35% infection rate in these children, 3% return to the operating room for washout of the most severe infections. Furthermore, the central and burdensome role played by the parents of children undergoing distraction translates to real costs as well. Specifically, these families are brought back to clinic each week in order to see how the child is enduring treatment and to see how the parents are enduring the manual distraction process. Lending further credence to the idea that this is a tough process for parents is a high volume of worried phone calls made by parents and received by nurses in clinic each week. And at these weekly visits, the child also undergoes serial skull x-rays to visually confirm expansion of the device. And all of these visits and tests represent not only a burden on our patients and their families, but a drain on clinical resources. So I've laid out the limitations of current distractors, and before discussing our technology, I want to talk about the market just briefly. So the global CMF fixation market is approximately $1 billion. This term fixation includes two things, what we call rigid fixation, which is plates and screws, and also distraction. So of that $1 billion market, CMF distraction represents approximately $400 million. And this figure is usually, a figure this size is usually too small to attract much attention in the medical device world, but we see an opportunity here, and I'll tell you why. As competitive as the orthopedic device space has become, the CMF space is relatively uncrowded. Looking at the chart on the right side of the screen, you can see the current players in the $1 billion CMF fixation market, largest of which are familiar orthopedic names, Synthes and Stryker, which together have captured approximately 75% of the market. An interesting thing to appreciate here, and something I will come back to, is the fact that other large med device players, Medtronic and Zimmer Biomet, have relatively small positions. So this is just a high-level look at the CMF fixation space. When we talk about CMF distraction, in particular, however, this uncrowded field becomes even more sparse, with only two companies having truly compelling distractor lines. Those companies are KLS Martin, seen in yellow, and the aforementioned Synthes in blue. And interestingly, well, I'll say KLS Martin, unlike its competitors, that also have product lines in spine, joint, and trauma, KLS Martin only has products for the CMF skeleton. And Synthes, its only real competitor in the CMF distraction space, had most of its distractors pulled by the FDA in 2014. So here's what we're left with: a small company whose livelihood hinges upon its dominance in the CMF distraction space, a large company who has proven interest in the space and has a relatively new gap in their portfolio following FDA product recalls, and three other large orthopedic device companies whose positions in the space are relatively weak and who have very weak or non-existent distraction product lines in their portfolios. So why am I going into all of this when we're really here to talk about the development of our technology at an academic center like Penn? Well, the reason is we believe that the current state of the CMF fixation market with these three facets that I just discussed presents the perfect opportunity for the development of a new type of distractor that each of these players has reason to be interested in. So let's talk about that new type of distractor that we're building. If you remember, before inundating you with jargon, I described our mission, that is to build a smart, fully implantable craniofacial distractor. Hopefully that means more now than it did the first time I said it, but there's still some more clarification that's needed. So here's a simplified rendering of our distractor expanding the lower jaw of a patient. The device we have begun designing differs from currently available distractors in three critical ways. First, instead of using a screwdriver to expand our device, a magnetic screwdriver of sorts that's part of an external controller is used. This alleviates the need for direct physical contact with the distractor arm. Second, since the magnetic mechanism alleviates the need for direct contact with the device, we're able to fully bury our distractor under the patient's skin with no activator arm poking through an incision. This is the most critical difference between our device and those on the market today, as it greatly reduces the risk of infection while also eliminating the stigma experienced by patients undergoing distraction currently. Third, the magnetic expansion is driven by an external device that's computerized and can automatically adhere to a surgeon's distraction protocol. And this alleviates that burden that we talked about earlier that's placed on the parents who have to manually drive this process at home. So with this end goal in mind, we partnered with Dr. Raul Manguram and 3 of his fantastic students in the Embedded Systems Engineering Lab here at Penn to build first proof of concept device. So this is what we put together and actually demoed at South by Southwest this year. And again, this is a proof of concept. Components are not meant to be to scale. But what we see here is a currently available distractor retrofitted with a new magnetic component on the top of that 3D printed skull there. An external controller device with a motor fitted to a corresponding magnetic component, and a smartphone that actually controls the external device over Bluetooth. From here, we started collaborating with the Biedermann Lab, which you'll hear more about shortly, to investigate the physical limitations of a device like this in order to answer a few critical device design questions. So that brings us to the Penn Health Tech grant and what we plan on doing with it. As you can imagine, a project like this, and like all the projects that we're hearing about today, incorporates multiple facets. Ours incorporates mechanical, electrical, software elements, and requires multiple parallel work streams and fairly significant amounts of funding. So because of this, we decided to focus our efforts surrounding the utilization of this grant specifically on prototyping of the mechanical components of our device. With our co-investigator, Mike Hast, who I'll talk more about at the end, along with a nearby engineering firm, we've developed the expedited timeline seen here. The work is broken down into 3 stages: research and concept refinement, preliminary engineering, and lastly, engineering prototyping. And we expect this work to take us into mid-March to complete. So you heard about the current state of distraction technology, its limitations, the market, the new type of distractor that we're building with the help of Penn Health Tech. Lastly, I want to tell you about our team, and then, if we have time, potentially some questions. So our PI, who you heard from at the beginning of the talk, and my mentor, Dr. Jesse Taylor, is an associate professor of surgery at Penn, board-certified plastic surgeon, fellowship trained in pediatric craniofacial surgery. At CHOP, he's the Mary Downs Endowed Chair of Pediatric Craniofacial Treatment and Research. He has over 100 peer-reviewed publications and is a key opinion leader in the field of CMF distraction. Our co-investigator, Dr. Michael Hast, is the director of the Biedermann Lab for Orthopedic Research, a lab that, among other things, specializes in the study of bone fractures, bone healing, and the mechanical properties of orthopedic implants. With his doctorate in mechanical engineering and significant experience in the orthopedic medical device industry, Dr. Hast brings critical engineering expertise to our team. I'm the last member of the team. As I said, my name's Ari West. I'm in my final year of medical school here at Penn. I'm also completing a master's in translational research under Dr. Taylor, writing my thesis on distraction and whether force measurements can be useful diagnostic and prognostic tools going forward. I've taken 2 years off of school to focus on clinical research in plastic surgery and pediatric craniofacial surgery, and largely from collaborations with Dr. Taylor, I've published extensively in the field. So there's definitely topics that I didn't cover in this talk, including the regulatory pathway that we envision, and from multiple conversations with experts in the field, along with intellectual property strategy, among other things. So happy to talk about that now if we have time or later. Thank you.